Hello and welcome back to our series from the Australian Dizziness Clinics.
All right, today we are going deep. We're going to build the clinical fingerprints for three really different causes of episodic vertigo: Meniere's disease, Vertebrobasilar TIA, and Vestibular Paroxysmia. Now, each one has a very recognizable pattern, and, each carries some pretty high-stakes consequences if we miss it. I want you to burn this idea into your brain, because this is the thought process we're going to keep coming back to. This mindset is just absolutely critical when you're on the front lines in the ED. I mean, this is a maxim that can quite literally save brain.
So how do we even begin to tell these conditions apart? Well, the thing that starts to unlock the whole puzzle, often just begins with one simple, powerful question about how long the vertigo attack lasts. Are we talking hours, minutes, or seconds? Okay, let's dive into our first pattern. This one is defined by a really unique combination of hearing and balance symptoms. We're talking about a disorder of the inner ear. The pathology of Meniere's is located right here, deep inside these intricate fluid-filled chambers of the inner ear. The best way to think about it? It's a plumbing problem, not a wiring problem. The proposed mechanism is this buildup of fluid pressure, a condition we call endolymphatic hydrops. And you can imagine, as this pressure ebbs and flows, it distorts and disrupts those delicate structures that are responsible for both our hearing and our sense of balance.
So this lays out the classic pattern you've got to look for. First off, the duration. The vertigo episodes last for about 1 to 3 hours. And here's what's critical. These attacks are coupled with very distinct audiological symptoms on the affected side: a hearing loss that comes and goes, tinnitus, and a sense of pressure or fullness in that ear.
Now, there's a really important subset of Meniere's patients who experience these incredibly dramatic events called Tumarkin crises. These are sudden, unprovoked drop attacks, but with no loss of consciousness. It's so crucial to distinguish these from a cardiac or neurological cause of collapse because, misdiagnosing this can lead to a whole cascade of unnecessary and invasive investigations. Okay, let's move to our second pattern. Now we're shifting our focus completely. We're moving from the inner ear's plumbing to the brain's blood supply. And believe me, this is a much more dangerous neighborhood. This is the 90-day stroke risk after a transient ischemic attack. And that risk is highest in the first 48 hours. That's why recognizing this in the ED is absolutely time critical. There's no room for error here. The problem we're dealing with here is transient ischemia in the posterior circulation. See, this network of arteries, it supplies the brainstem and the cerebellum, which are basically the body's core balance and coordination centers. So even a temporary disruption of blood flow here can cause just profound vertigo. To help us stratify this risk, we use the ABCD score. It's really just a simple checklist that assigns points for key factors. You've got A for age over 60, B for high blood pressure, C for clinical features like weakness, D for how long the symptoms lasted, and that final D for history of diabetes. Now, the key is how we actually apply this score. A total of 4 or more points, that puts the patient firmly in the high-risk category. That's our trigger, our signal for admission, and urgent vascular imaging, like an MRI with diffusion weighting or a CT angiogram, to make sure we're not missing an evolving stroke.
But, this is arguably the most important point about this entire score. It isn't perfect. In fact, it's notoriously less reliable for these posterior circulation events, which, let's face it, often present with just vertigo and nothing else. So please remember this. Your clinical suspicion in a high-risk patient has to always override a deceptively low score. And that brings us to our final pattern. This one's the rarest of the three, and honestly, because of its really strange presentation, it's often misdiagnosed for years. The mechanism here is thought to be neurovascular compression. You've got a blood vessel that's pulsating against the vestibulocochlear nerve, and it's causing these brief, uncontrolled bursts of firing. It's something almost like a seizure of the nerve itself. Now, because the attacks are brief and they're triggered by head movement, you can see why it's so frequently mistaken for BPPV. But the patient's story is going to give you a totally different pattern. Your BPPV patient says, "Oh, it happens when I roll over in bed." The paroxysmia patient, they say, "Doc, it happens every single time I just turn my head." Here's something you don't see every day. Uniquely, the diagnosis here is often confirmed with a therapeutic trial. So if you suspect this pattern, you can start a low-dose anti-seizure medication like carbamazepine. A dramatic positive response is actually considered diagnostic. Pretty wild, right? Okay, let's pull all three of these distinct patterns together, side by side. Seeing them in contrast like this really helps to solidify that pattern recognition framework for the next time you're faced with one of these patients. So this table gives us a really clear, actionable mental model. Just take a second to let it sink in. For Ménière's, you're thinking hours plus earring symptoms. For TIA, it's seconds to minutes plus vascular risk factors, and always applying your clinical judgment over just the ABCD² score. And for Paroxysmia, you're looking for dozens of seconds-long attacks every single day. So, look, if you remember nothing else from this, please remember these three things. Ménière's is all about the ear, a TIA is all about vascular risk and a very healthy dose of suspicion, and paroxysmia is that strange pattern of multiple daily seconds-long attacks that gets better with a specific medication. In our final explainer in this series, we're going to cover the really important cardiac causes of episodic vertigo, and then we'll integrate everything into a single bedside ED algorithm to help you get the disposition right every single time. Thank you so much for watching. We really encourage you to visit our website for more resources on dizziness, vertigo, and imbalance. And please don't forget to subscribe for future explainers.